So let's start. Good evening, everyone. I am Shrenik Shah from Ahmedabad, stage 4 vocal cord cancer survivor in my 27th year and patient ambassador of Indian Cancer Society, Delhi branch. Before I introduce our eminent guest speaker, I would like to share with you why we have come up with this webinar or a series of webinar that is titled as Conquering Cancers. These days, a lot of informations are available on our web browsers, particularly about cancer and treatment protocols related to cancer, etc. But today and every week from now onward, we are bringing cancer specialist oncologists for a simple reason, for sharing their knowledge, for sharing their experience and expertise. And one of the key reasons why we are doing it is for the public, for the community, that with a clear indication that if you are not medical professional, please make sure not to follow those information available on web browsers. On the contrary, I strongly recommend to get in touch with the related expert and cancer specialist. I mean, whoever you are interested or willing to. So this is the reason. And one more thing, we are bringing the top of the line oncologists across Pan India. These oncologists, they have their own priorities and they cannot give you individual lot of time for, sharing the knowledge and experience and everything. So with this webinar, we are trying our best to provide you comprehensive information pertaining to various treatment protocols for cancer. Today, I am super excited to invite and introduce our eminent guest speaker, Dr. Pooja Nandwani Patel, Madam. I knew her for so many years, and earlier she was head of the department at JCRI, India's second largest cancer institute, and I must compliment her for saving the lives of countless cancer patients and survivors by providing uh, quality radiotherapy. Apart from that, she has been trained in US, UK, Canada, and so on. And on top of that, she is the she is the director of the Radiation Oncology Department of Sterling Hospitals, Ahmedabad. And on top of that, if this is not enough, she is the president of Gujarat of the Association of ROE, Association of Radiation Oncologist of India, Gujarat chapter. And let's have our invaluable insights, pertaining to the radiotherapy. And Madam, floor is all yours now. Welcome on board.
Thank you, Shrenik bhai. Namaste, good evening, one and all. At the outset, first of all, I would like to congratulate and thank the Indian Cancer Society Delhi branch for coming out with this excellent initiative of creating awareness for the community. Awareness is really very important, because for the reason that it is the first step to prevention. And why would I say that prevention is very important? For the reason is we all are knowing, we are seeing that cancer incidence has been increasing exponentially in the last few decades. But what is important to understand is that whatever numbers we see, out of these numbers, about 40 to 50% of the cancer cases are preventable. That means we have a lot to do on this segment, and prevention can only be done when we have awareness. So I'm so glad that the Indian Cancer Society Delhi has taken this initiative and also chosen Shrenik B as a perfect person to be the moderator, because I have been knowing him for, I think, more than a decade, and I really admire and respect this person for the reason that he is a cancer survivor and winner for sure. But apart from the routine treatment, when he finished and he came out as a survivor and winner, he has just chosen a different path of inspiring others, motivating others, and his words really make a lot of impact. So I'm so glad that Shrenik Bhai is moderating the series, and no one can be as more perfect than you, Shrenik Bhai, in conducting this series. So congratulations to you as well, and I hope there's lot of more power to you for conducting this series. So today we are here to talk about specifically about the role of radiation therapy in the head and neck cancers. It is this treatment which I would say it is much more overrated in terms of side effects, and I would say underestimated it in terms of effectiveness. So we will understand how. So when I was discussing that what topic we should consider for this webinar, I specifically told Shrenik Bhai that we should have all the myths related to the radiation to be discussed. What are the actual facts behind it? And when we understand that radiation has been always many times been seen as with lot of fear, it is important to understand the advances which has been there in the last 3-4 decades. Always tell to my patients that you don't should not fear from the treatment, because the fear of the treatment sometimes creates more damage than the cancer itself. And radiation is one such modality. If somebody has their bitter experiences because the machine was not advanced or it was done long back, then you will carry that experience, that memories for lifetime. But no, radiation is quite different in today's era with the modern therapies. So let's start from the basics. We all know that in the cancer, the scientific treatment are three basic modalities: the surgery, chemotherapy, and radiation. Surgery is very easy to understand. It is the removal of the disease. Chemotherapy is the treatment with the drugs or the injections, some which is primarily a poisonous thing to kill the cancer cell. And radiation, what is radiation? So radiation is basically an X-ray. It is the same X-rays which are being used in the diagnosis by the radiology department, but the basic difference is there the voltage is less, so you primarily use it for diagnosis. You get black and white pictures. You might have seen your clinicians; they are reading sometimes the pictures with black and white, and that is what is the X-ray in the low power. It helps for the diagnosis part. But in my field, these X-rays are high in voltage and they primarily target the DNA of the cell, which is the main thing, and that is why the cell gets dead. So we are trying to target only the affected, the cancerous areas. Now, the routine myths what people have in the radiation is, when I talk about radiation, the word is so deadly that people think it's going to be a very painful treatment. Patients, when they come for the first consultation, they ask me, Doctor, what would I feel? Kaisa lagega mujhe? I always tell my patient that radiation is absolutely a painless procedure. You don't feel anything. It's not that you will get a feeling of as if getting burnt or there is any cold, extreme cold sensation, or radiation is going to be a pin pricking or is going to be a very, very, very painful. It's absolutely painless. People sometimes understand that radiation is going to be harmful to others, especially the patient and to the surroundings where he is going to stay with his family and friends. I always tell my patients that once you're out of the machine, you're completely like us as a normal person. You're not going to emit radiation to your family members or your friends. So there is no such fear, or you should restrict keep the patient in isolation, because at this point of time of his journey, in fact, a patient needs a lot of comfortness, a lot of soothing, a lot of support, and the friends also, because I always personally believe science is definitely a thing which is going to work, but there are a lot of positive vibrations, positive environment, a feeling of comfort and wanted, which really boosts the moral of the patient to go through his entire journey and come out as a winner, like Shrenik Bey has already done this. So It is not that the radiation will be emitted from his body and it will be dangerous. So if you have your kids at your home or any pregnant lady or any elderlies, feel free during your radiation therapy, because radiation therapy is one such treatment which is not going to be finished in just one single day. It's going to go for some weeks or sometimes even months. So feel assured there is no issue with that. How do we decide, especially in the head and neck cancer cases, that when to give radiation? Because this is also one of the myths with the head and neck cancers primarily, that people usually think head and neck cancer hai, to bas surgery ho gaya and then your treatment is over. No, it's not like that. Radiation is used in head and neck cases in majority of the time. I would say, I'm not exaggerating. Please mind my figures when I speak. It is almost about 90 to 95% of the cases where head and neck is radiation is being used. The intention would be different. If I explain you in a simple manner, when the surgery is done, for example, let us understand head and neck cancers means what? It is primarily the oral cavity, that is the tongue and the cheek. Then there are oropharynx, that is the base tongue, the tonsil, the posterior part of the tongue. Then there is the hypopharynx, which primarily includes the early part of the food pipe, the postcricoid, the hypopharynx. So all these areas, when we are targeting to cure the disease from cure the patient from the disease, we sometimes, majority of the times, do use surgery for sure. But that story does not end there. You may have to club it, or you may have to complement your surgery with radiation or even chemotherapy, depending upon the stage. So as once the disease is out from the body, the disease doesn't come back again. So there, the radiation is used in the post-operative setting, and it goes for about, say, 6 to 7 weeks. Sometimes radiation would be given as a curative method. And let me give you a classic example of carcinoma of the vocal cord or the voice box. It was in 1950s when we first realized that long back before 1950s, what used to happen? Anybody who has a vocal cord cancer, the voice box cancer, if it is the early stage I'm talking, they remove the tumor. The patient is disease free, but the patient also loses his voice box forever. But then in 1950s, a famous veteran affairs study came which showed that if you use radiation as an alternative, you can give the same results like the surgery. You can make the patient disease free. And at the same time, you can preserve the voice box so that the patient does not lose the voice. Of course, I'm again mentioning it's the early stage I'm talking about. And then with this role of radiation, this angle of radiation being explored, that it is used in the curative setting, definitive setting, there were many other sites also like cervix, prostate, where we are trying to give the same rates equivalent to surgery and preserving the organ. So that was the first time we used the radiation in the curative setting. There, the therapy would go a little bit longer, say about 6 to 7 weeks. Then there's another indication where we have been using radiation before the surgery to make the surgeon comfortable in operating and the results being better. No doubt in head and neck, this has a very limited role, but yes, still till date, in the sinus tumors, we first use preoperative radiation, which goes for about 4 to 5 weeks, and then do surgery later on. And then this last segment, no matter we are so active on these type of platforms, unfortunately, patients do land up in advanced stage where the patient has complained of bleeding or pain. There we give in a short schedule of 1 or 2 weeks just to make the patient symptom free. That is called as palliative radiation. So there are different ways, different intentions when we use the radiation in the head and neck treatment. So the myth that only surgery would be sufficient, no, it's not true. So we have to sometimes complement with surgery before or after, depending what intention we are using. Another myth what people have is that when we give radiation, there will be hair loss. So I'll make a very broad clearing here that radiation, you have to understand, is a local treatment. So the way you do a surgery, surgery is also a local treatment. You remove the tumor out. The radiation is also local. So there are many times patients very apprehensive when they come for chest wall radiation or breast radiation or radiation to the prostate or the cervix into the abdomen. They ask me, Madam, will we lose our hair? And then I always explain that radiation is a local treatment. So if you're receiving radiation to not to your scalp, then no, never will your hair go. So feel rest assured about this thing. That sometimes, many of the times when we are giving radiation, we club chemotherapy. There may be some agents also which might cause hair loss, and you may think that the radiation is causing hair loss, but no. Till the scalp is not touched, radiation does not cause any type of hair loss. Then, as I mentioned, patients sometimes have a myth that once the patient has to be given radiation, you have to make the utensils separate. You have to make sure that the patient only uses that washroom and nobody else would use. You cannot use the share the same bed. No, it's not like that. It is not an infectious. The patient is not going to be harming anybody. So it is again a myth that patient has to be kept in isolation. I again repeat, the more love and the comfort the family members or friends are giving, the more easier is the journey of the patient through the entire treatment. Then there's another myth which is like that when you give radiation, the disease will spread exponentially, it will be fast. No, it's not like that. As I mentioned, there are certain areas where we are trying to give radiation only with a palliative setting, matlab, only with a symptom relief. And suppose if somebody in your, because we live in a country which is a social, lot of social contacts are there. And when someone knows that this person has cancer, the family would visit or the friends would visit, and unintentionally they will try to share some experiences of someone who might have a disease which is totally different, has an advanced stage, and there the radiation was given with the intention of removing the pain or stopping the blood, and then eventually, unfortunately, that patient suppose has succumbed to the disease. So that impression will be carried. Okay, radiation was given, and then the patient died in another next 6 months. And then the people have the same thing in their mind that when you give radiation, the disease spreads. No, it's not like that. That was totally a different disease you're talking about. So with radiation, your disease never spreads. In fact, radiation is primarily intended to control the disease, to cure the disease. Then people have a myth in their mind that radiation side effects are going to be very bad. Now, I always start with this first sentence when the patient asks me, the doctor, is this going to be a very treatment which is going to be having a lot of side effects? So first thing you have to understand, any treatment when you start with, when it has going to be having effects, definitely it will have some side effects because the word is side is only attached with effects. It means the side effects are bound to happen. But again, I repeat, in today's era, when the technology has gone leaps and bounds advanced, the therapies have become so much particular and directed to that particular area we're intending to give. So the side effects have gone very less. So as Shrenik Bhai said, I have been working in a regional cancer center for 15 years. Then I shifted to a private setup, Sterling. So with this 2 decades of journey where these modalities have really changed in the last 2 decades only, I can see, I can witness what an earlier therapy used to do and what today's therapy do. Earlier, the machines were not advanced. They were very simple and conventional. Conventional means, for example, if I want to treat the tongue over here, there used to be a field like this, and it used to treat everything which used to come in the way, the parotids, the spinal cord, the eyes, and everything. But today, with the advanced technologies, we have machines which are just concentrating the affected area, and all the nearby normal organs, the innocent organs, they are tried to spare as much as possible. No matter, you may have some sort of side effects, but they are very temporary. They are during the radiation time only. And with this advanced machines, in fact, those side effects has also gone to a very lower grade. As some compared to a grade 4, it has come down to grade 1 and grade 2, but they are temporary, they are quite manageable. So these side effects are not such a big problem for which you should defer your radiation. What side effects, if I specifically talk about, because head and neck, when we are talking today, especially, head and neck, what happens is you have a lot of ulcers in the oral cavity when you're treating the oral cavity. So the patient loses the taste. The patient has ulcers in the mouth during the third or fourth week, especially when you club it with your chemotherapy, if it is indicated according to the stage, then the reactions may go a little bit 20-30% higher. There may be some sort of pigmentation to the area you receive the radiation, but again, it is a temporary one. It will go away once your radiation is over. Patient may have difficulty in swallowing. Patient may have a little bit of change in the voice because of the edema going to the vocal cord area. But again, these all side effects are quite manageable and have decreased to a very, very, very lesser extent in today's conformal machines. And once your treatment is over, mostly in 2 or 3 weeks or 4 weeks, these all radiation side effects will go away. So none of these side effects are going to be permanent. In fact, today, when I am telling about the example of a voice box cancer, where we initially went down to surgery to a non-surgical approach, we always have thought that we should give a treatment where we try to maintain the patient's quality of life as before. It's not just important to make the patient disease free, but making sure that patient enjoys his life too. It is not that the patient always keep on repenting that why did I survive from this disease because I have so many side effects. We don't want to make the patient's life miserable. So we have always been trying, and thanks to the technology with us today, it has really helped us to make our side effects go very, very less. and possibly making the patient's quality of life as similar, as matchable to what the patient had before the cancer. What advances I'm exactly talking about is all these newer machines you have seen. Suppose I told that initially was the era of 2D therapy, where we used to give radiation, and has to be the portals used to be has the same with the disease affected and the nearby, to today's 3D era. You might have somebody who is have connection or would have gone through somebody's treatment protocol. You would have heard a word of IMRT, that is intensity modulated radiation therapy. So what exactly happens is, with the newer techniques and the newer machines, we try to manipulate the beam's intensity, the machine's intensity, of where we try to give a high intensity of radiation to the affected target area and spare the normal structures. Then we have another technology known as IGRT, where when we are making the plan very beautiful, but we make sure that it is also executed in the same way by taking images daily. So advanced machines have a capacity that they have an inherent CT scan on their machine only. So daily before treating, we again take a scan. We match it with the daily with the planning scan, so that we make sure that the planning was perfect and even the execution is as perfect as possible. So with all these advances, the machines and the softwares, advanced software, like I tell you an example, how do we plan actually? So we first make some type of mask or some sort of things which we'll see that the patient is going to be there into the same position daily. And then we take a scan. If you're doing a 3D plan, the CT scan is mandatory. Then we take a scan. Many of the time it's a plain scan. We just want the patient's scan to be seen on our computer desk. Then we draw each and every organ, where to give radiation, where not to give radiation. And once the plan is, we have a team, we are a team actually, where we also have medical physicists with us who generates the plan. As a doctor, I try to give the prescription that make sure the dose is going to this area, not to this area. He will play with the computer, generate plans, then sit down with me again, and we decide that which plan is the best out of all, and then we execute that plan. So when that plan gets transferred to the machine, as I said, if you have an advanced machine, you again take a scan, you match it with your day one scan, you make sure it is the same way it was being planned. Because otherwise, if you're moving even a zero point 0.5 or 1 centimeter, you will actually bombard some other area. So with this does not happen when you have an advanced machine. You can easily correlate with what has happened in the surgical field. Long back, it used to be a very open surgery. The surgeries were very morbid. There used to be a lot of morbidity, a lot of mutilating surgeries. But now, with advances, the surgeries have become more and more precise. We have progressed from open to laparoscopic, and today we have come to the era of robotic. And with all these, we have made sure that the patient's surgical journey is quite smooth, the recovery is fast, the blood loss is less, the patient's entire journey becomes as smooth as possible and better back to work as early as possible. Even the chemotherapy, if I tell you in a nutshell, long back when we started, the chemotherapy used to be a broad spectrum chemotherapy. But then having understanding the science, the biology, the tumors, our now chemotherapy drugs, they have become more and more specific, more and more targeted. You would have heard words like targeted chemotherapies, immunotherapies. These therapies which are targeting actually a receptor level, so that we make sure that the patient gets the maximum therapeutic benefit. And with the multimodality treatment approach, most of the hospitals, which are good hospitals, they have a multimodality concept where MDT is usually done. MDT means multidisciplinary team approach. When we see one patient, we have everyone in the same room, right from the diagnosis to the treatment. Like we have the pathologist, the radiologist, the nuclear medicine specialist, the surgeon, the radiation oncologist, the medical oncologist, even the staff, the dietitian, the counselor. We sit down individually for the patient. We designed an individual plan for that patient together, and we make sure that the patient is going through that plan. We do interim evaluation to understand that whatever we have proposed, the patient is going through the same plan and is also getting the desired benefit. So today's era, with all the advances in the machines, in the surgical expertise, in the chemotherapy drugs, even we have also made very much more and more individual plans for every patient to see, because all our patients, all our five fingers are not same. So suppose there are 10 patients with the same cancer diagnosis, with the same stage, maybe sometimes one or two patients would need something different as a protocol. So when you have a good hospital, you do a MDT, that will help you to get more and more better results. I think this all is what I would like to convey, and I would like to have a lot of questions from your side, so that the purpose of coming today here to create awareness is well served. So over to you, Shrenik bhai.
Thank you, madam, for adequately explaining the radiotherapy options and its myths. Now, before we get any questions from the audience, uh, I have few questions to ask, and what is very important is if radiation is required for second time, can it be given?
So very good question, Shrenik bhai. So this is again where the advanced techniques come into picture. Earlier, when I remember, I used to study the radiation 20 years back. We used to go with a decorum or with the principle is that if the radiation is required, specifically the same site I'm talking, if it is a different site, then so there are no worries. But if you have to give radiation to the same site again, then we used to have a common principle being followed that at least we should have 3 years difference so that we can minimize the toxicity and side effects. But the beauty of the advanced machines is today is that with more and more refinement and with more and more precision, even if it is a radiation to be given in 6 months' time, also we can do that. There's something called an SBRT, stereotactic body radiation therapy, which is altogether a different technique. But this technique helps us to give a higher doses in lesser number of fractions and precisely to that radiation area only, to that designed area only. So that is why these techniques, it is really possible even to re-radiate.
Right. Now, madam, there is one question from Priya Parmar. She says, she is asking, like, if there is a pregnant woman, is it possible for her to undergo radiotherapy for a oral cancer?
So very good question again. So yes, first of all, any such today you have specifically asked me for oral cancer. Let me make it clarified for other general wise also. Whenever a pregnant lady comes and we have to give the radiation, we always make sure that can we avoid as much as possible the radiation therapy possibly. If it's not just a head and neck, suppose at the site, and if it is possible to give alternative things like say chemo or surgery, we would prefer to do that. But suppose head and neck is the site where, as I mentioned, radiation is primarily being used. So if we have to do, we can do that. There is something called as a lead shield, which we make the patient wear so that at the time of the radiation, there will be lesser and lesser possible radiation going to her uterus or the abdomen area. So it is possible, but then you have to make sure that we all follow this measure strictly. And it has to be always consulted properly in the team to understand the pros and cons. Let me give you another example. A patient of a breast cancer, she is pregnant and we have to start her therapy. So at the time of chemotherapy, again, this can be a problem because there can be a hindrance of the chemotherapy being a very toxic treatment and she is pregnant. So we at that time decide how to proceed. Can we do a surgery first so we can delay a little bit of time? And at the time, then we can give the chemotherapy later on. So yes, it can be possible. It is only to be properly decided in a clinic. And even an oral cancer patient who is pregnant can receive radiation.
Uh, one more question in the same connection. What could be possible damage to the child, child, the pregnant lady when radiotherapy is given. So, percentage or whatever, in whatever manner you would like to explain.
So the abdomen or the uterus is quite far from the head and neck region, so chances are very less. And once we have decided thoroughly that yes, we are going to go with radiation, we make sure that the patient does not or the child does not has any damage. We don't want that because of the radiation there is any mutation at the child level also. And we have a child who is mentally retarded or physically retarded or is born with some sort of a genetic defect. So definitely, if we are making sure all these parameters, we have all the discipline maintained in the department, I think that is not a barrier to go ahead with radiation therapy.
Uh, One more question, which is common for me and from Priya Parmar, like, can anyone avoid radiotherapy or radiation?
So this was the purpose of today's meeting, that the fear should go away. And as I mentioned, it is always a combined treatment approach. Many of the times, if we see that yes, surgery, like as I mentioned, the oral cancer. especially the tongue and the cheek, the main treatment is surgery only. So we definitely do surgery. And if you're very lucky, your tumor stage has come out to be very less. The chances of relapse or the disease coming back is very low. Many of the times, I've myself said to the patient, you can observe. But having said that, you should always remember that if radiation is required, do not have fear from the therapy and should not avoid. If radiation is indicated, definitely you should go ahead. But yes, there can be a chances because of the stage of the disease, because of the lower chances of the disease coming back, we can avoid radiation. But again, it has to be a decision taken by the treating physician or the surgeon to decide what should be the ideal treatment for this patient, what combination to use.
So, so according to you, to avoid recurrent cancer, to avoid recurrent cancer, the radiotherapy or radiation is a must.
Yes. So that is again depending. Like if the operation has been done and if we see the so what is how we decide the patient needs a post-operative radiation therapy. So once the patient has been operated, the report what comes from the laboratory, which will study that what was the dimension of the tumor, how much extensive it was it going to the bone, was it involving nearby structures, was it going to the lymph nodes, then accordingly, we decide that what is the T stage or the N stage, and then we decide that if it is going to be aggressive, it is going to come back again, then we need to give radiation. If the disease has spread to the neck node region, then probably we need to complement with radiation, with chemotherapy as well. Chemotherapy, when given in a concurrent setting in the head and neck, is usually very easy to tolerate because unlike the other chemotherapies you have heard in breast or lung, it's a full dose chemotherapy. It's usually a combination of two to three drugs. But when you give it a concurrent setting, it is usually a single agent. Most of the times it's a flattening, or sometimes use some targeted therapies. So and it is given on a weekly basis and easier to tolerate.
Great, thank you. One more question. What is palliative radiation?
Very good. So as I mentioned, with a lot of all efforts from done our side, from patient side, but unfortunately, patient has landed up in an advanced stage. And no matter any good surgeon, any good radiation oncologist, or any chemotherapy medical doctor would not be able to cure the disease completely. In such advanced cases, the patient has a trouble of the symptoms which is harassing, like the bleeding or pain, or suppose if the tumor was is in the hypophysis in the neck region and is encroaching the spinal cord, you may have spinal cord compression features, you may have sensations going to your hands, a lot of disturbance. So in those circumstances, we can just palliate. Palliate means make relief of the symptoms. So it is just a procedure which is intended not to make sure, not to see that the disease is going out completely. It's not possible at all from any hands of a surgeon or a medical oncologist or radiation oncologist. But yes, we can at least make the symptoms go as minimum and or completely go up so that whatever amount of time the patient has, say about say 6 months, 1 year, whatever, according to the stage, we can at least make the patient's lifespan at that time as comfortable as possible.
Thank you. Now of late, proton therapy is becoming very popular. I mean, of course, it's quite expensive. There are limited number of hospitals in India. I mean, providing such treatment. So we would like to know a bit more about proton therapy as well.
So again, a very excellent question. So yes, proton is definitely a very good therapy, but again, I would say not every patient would be an ideal indication for proton. See, when you have to keep, suppose if you're talking just on the scientific basis, let's keep the financial part aside, but we just talk about science. So there are only very few limited indications where proton gives a better result as compared to our routine photon therapy. Pediatric tumors, skull-based tumors, or sometimes a tumor which is coming again, second time, third time, recurrent areas, and there is a lot of normal structures very closely in adherence to the targeted area. There sometimes proton can really help. Why? Normally, what happens with radiation, if I show you the graph, what happens is normally the radiation in a normal protocol would be like this, slowly going up and then slowly going down. But in proton, we have a concept of Bragg peak where you get a sharp rise and a sharp fall. So in that circumstances, the normal structures which are nearby the target area, you can make sure that they get as less dose as possible, and you can have proton seeing more benefit than the routine photon therapy we give. But again, I repeat, it does not mean that every patient, say, for example, every breast patient, every lung patient, every head and neck patient would need a proton therapy. It is selective cases where we decide that yes, proton is going to be helpful. On a larger note, if I say in head and neck, if it's a routine, simple case, proton gives best results, equivalent results. So you need not to rush for the expensive proton therapy.
Well, I am having altogether a different question. I mean, since we are talking about radiotherapy, I would like you to, I mean, give us some information or hospital statistics about the success rate of radiotherapy between male, female, and child children or other pediatric cancer, particularly pertaining to head and neck cancer. The,
So you're
the,
asking,
the success rate between male, female, and children.
so when we talk about the incidence, for example, like if I talk about the incidence of cancer cases in India, you would see that about it has grown exponentially. What we see in 2020 was something around, say, 13 lakhs or so, has come down today in the era is around 14.5 lakhs. And when we see these all cancer cases increasing, when we talk about the role of radiation and their success rate, I would say when you talk about pediatric, now pediatric, you see most commonly what we see in pediatric is the blood cancer, leukemias, which are normally known. Leukemias are very much curable. Only you need to have a proper diagnosis and early intervention as possible. There, the success rate, radiation has a limited role, especially for giving, when we give the radiation to the chemotherapy in the leukemias, it is the brain part which actually does not receive the chemotherapy much because there's a blood-brain barrier. So there can be chances that even the patient is cured from the blood cancer, he can have a relapse in the brain. And that is why we give prophylactic cranial radiation. So again, it's a curable malignancy and it is very a limited number of radiations we are giving to the head and neck, to the brain region. So the chances of the success rate of radiation in a pediatrics is excellent. Chances of success of radiation therapy in a voice box, in cervical cancers, prostate are very good. See, I can give radiation anywhere from the top to the bottom. What I need to understand is the radiosensitivity. That means what is the chances that tissue will respond to the radiation therapy. So voice box, the vocal cord, the cervix, the prostate, these such tumors where the results are so excellent that even we can keep it as an alternative to surgery. We can omit the surgery and just with radiation, sometimes combining even chemotherapy as required, we can club it and we can make the patient disease free and give equivalent results to surgery. Now, if I talk about head and neck, the success rate of radiation is good, but then again, as I said, there are certain sites where surgery is the must. For example, tongue and cheek. So you have to do surgery, but you complement your radiation with it so as to prevent the disease coming back. So, say, for example, a very beautiful done surgery with an expert, skillful hands, the disease is out. But still, if the disease is looking aggressive, there are chances that the disease would come back in 70 to 80% of the cases. But when you complement the radiation in such cases, your chances would go down to 10 to 20%. So that's a huge benefit if you see. The risk which is sitting on your head, about 70 to 80%, is now substantially being reduced to 10 to 20%, which is an excellent benefit you get with addition of radiation. So radiation, and there are certain sites like the base tongue, the nasopharyngeal. Nasopharynx is the tumor which is seen behind the nose. And these, in fact, tumors are the areas where we don't do the surgery at all. We try to cure only with radiation and chemotherapy. And again, they are very excellent tumors, radiosensitive tumors, chemosensitive, where the entire disease would go away only with radiation chemo. But again, as I said, you have to make it to sure that your case has been discussed in a multidisciplinary tumor board meeting. You decide how to, like for example, of nasopharynx, I tell you, there are many of the couple of times we have decided that we will initially give first chemotherapy and then give radiation and chemotherapy later on. There are many of the times we have given radiation and chemo first and then given some full doses of chemotherapy. So this is all individual to individual variation. You just have to make sure that the treating doctors, whoever it is, radiation surgeon or chemotherapy doctor, they all are aligned on the same thinking process, on the same level, so that we can give the desired results to the patient and as minimum side effects, because no matter whatever area we are sitting today, still there are a little bit of side effects, but we try to see that as treatment modalities we can reduce as minimum as possible to reduce the relevant side effects. And this is why awareness, what we are here today makes a role. Awareness is not in terms of just to understand what is the what is the symptom, what is the causative factor, but also to understand what are the treatment modalities available. So you judiciously use your treatment modalities, you get the highest cure rate, you get the best quality of life, and of course, when you're reducing the number of the treatment modalities, you're naturally reducing your related side effects as well.
Like one more question. Okay, from Priya Verma, you would say for a lot of head and neck cancer, what role does tobacco usage play?
I would say in head and neck cancers, the tobacco is 100%. So, see, tobacco is dangerous in any form. Like I'll give you one example. You asked me something related to the pregnancy, right? When you take tobacco, the lady who is consuming tobacco, not only the tobacco is going to affect that lady, it is also going to affect the child which is there in the uterus. So tobacco is that dangerous, which is just going to harm your body. There is no single one benefit you can count on your finger which gives effect with the tobacco or good effect. It is only that feeling of good feeling when you get when you take in any form that is also temporary, but the harm is going to be permanent. If you see about the head and neck cancer cases, tobacco and alcohol are said to be 100% related for the causative of the cancer. And let me make one disclosure over here. I sometimes get very high affluent families coming for the treatment, and especially like saying about the vocal cord. Vocal cord, you will patient will say, I डॉक्टर मैंने अपनी पूरी जिंदगी में कभी तंबाकू नहीं खाया, कभी दारू नहीं पिया, कभी गरम खाना नहीं खाया, कभी कुछ नहीं किया, मुझे क्यों ये हुआ? So it is not always 100% in the sense you have certain other factors. Like for a voice box, people say those people who are singers or teachers who have been using consistently the vocal cord, sometimes they have increased chances of the voice box cancer. So it always remember that causing of the cancer is not just a single factorial, it's a multifactorial. But yes, for sure, tobacco is going to cause cancer for sure. So make sure you remove the tobacco usage from your life today itself. And mind it, tobacco, the form of tobacco usage, say suppose you're smoking, that smoking will not only affect you, but passively the members who are around, it is going to affect them also. So this tobacco is as dangerous as possible, especially to the youth, I would convey, because nowadays I see with all these, advertisements, with all these heroes in the movies, that no matter they write smoking is injurious to health, tobacco is injurious to health, with any of the clippings coming where they see that, and our young crowd will always follow these celebrities. They see them chewing tobacco, they see them smoking, they see them drinking. It becomes a fashion. It becomes a peer pressure. I would look tougher if I don't smoke. I will look, क्या है मेरे में कुछ हिम्मत नहीं है मैं तो एकदम भाग गया हूँ. Please don't consider. Be a smart. Smart is you avoid tobacco and alcohol in all forms.
Uh, you're very rightly given example that even when I was diagnosed with this stage 4 bone cancer, I had no habit of tobacco, never smoked, strict vegetarian and non-alcoholic, but it just happened. So, this is kind of a part of the life one has to accept by default. Uh, Now, madam, there is one more question from Vaishali. She says she's asking like combination of chemo and radiation is more effective for in oral cancer or only radiation therapy.
So, Vaishali, very good question. But every time how we decide the modalities according to the stage of the disease. Most of the times we have realized if the disease has spread from the initial area of beginning to the neck, then many of the times we have to involve the chemotherapy as well. But having said that, as I mentioned before, chemotherapy is not a big concern as compared to other sites where it is usually a doublet or a triplet given in the full dose, lot of side effects. You would see that a breast patient majority of the times are losing their hair. Nowadays, even that has gone with newer things called as cool therapy, where you're trying to give the chemotherapy the best effectiveness and trying to preserve the hair also. But I'm just trying to give an example that in fact those are the areas where you would have a higher chances of losing your hair as compared to a patient of head and neck who is on chemotherapy, because here the chemotherapy majority of the times are used in a single format and in a low setting. In fact, it is called as radiosensitizer, where the effect of chemotherapy is to enhance the effect of radiation. Mind well, This is again a different chemotherapy where it is used in the head and neck in a preoperative or a neoadjuvant setting. Like when I said, suppose if it's a very advanced oral tongue, there I want to give chemotherapy to downstage. So there again, it can be a 2 or 3 drugs. So you may have chances of hair loss and other issues. But yes, the comparatively the side effects are less. So you should not have any fear from adding chemotherapy to your radiation protocol or your surgical protocol as indicated. Because as a clinician, everyone is thinking about you as the patient that yes, we want to cure the patient. At the same time, we want to make sure that the quality of life as possible matching to the pre-cancer stage. So we will also try to use the lesser number of modalities, but even if the stage warrants the use of chemotherapy, don't refrain, don't be fearing, try to involve whatever the best is involved. You can of course discuss with your clinician that can we have some other alternative, can we have some other chemo drug which can have less side effects. The chemotherapy doctor, the medical oncologist will decide what is the best chemotherapy agent in your case, according to your body, according to your stage, according to your gender, what sort of chemotherapy we can use so that you have the effect also and you have lesser side effects as much as possible. Shrenik bhai, I think you're frozen. Hello.
हेलो हेलो
Yes.
यस
Yes.
मैं ये पूछना चाह रही थी कि अभी जैसे आपने बोला था कि गरम नहीं खाया है और उसकी वजह से मुझे कैंसर क्यों हो गया, तो क्या ऐसा होता है जैसे कभी कभी हम गरम चाय या कॉफी ऐसे पी लेते हैं और हमारे मुंह के अंदर की ना 2-3 लेयर स्किन की निकल जाती है, तो उससे क्या कुछ ऐसा लॉस हो सकता है?
नहीं, ऐसा होता नहीं है, बट यूजुअली लोगों को क्या लगता है कि हम शायद बहुत गर्म खाना खाते हैं इसलिए हमको हुआ, लेकिन काफी बार आपको सिंपली ये सिर्फ समझना है, ये जो बाहर मुझे दिख रहा है उसको हम स्किन बोलते हैं, ठीक है। और मुंह के अंदर जो हमारी लेयर है उसको हम म्यूकोजा बोलते हैं। बार बार कुछ गर्म खाने से क्या होता है कि हमारी म्यूकोजा डैमेज होती है। उससे काफी बार हम लोगों को, जैसे आप देखोगे आपको अंदर, या आपने गर्म कुछ खाया आपकी जीभ छिल छिल गई, या गर्म
हाँ
गले में कुछ आपका वो हुआ, उससे कैंसर नहीं होता है,
हाँ।
बट अननेसेसरी ये टाइप के डैमेज भी लॉन्ग टाइम पे आपको आगे कुछ और भी इफेक्ट्स कर सकते हैं। इससे अवॉइडेबल होना चाहिए कि आपको एक्सट्रीम खाना नहीं खाना चाहिए, एक्सट्रीम गर्म खाना नहीं खाना चाहिए। बट ऐसा कोई प्रूवन नहीं है कि अगर आपने गर्म खाना खाया है तो आपको उससे कैंसर हो जाएगा।
ओके ओके, थैंक यू सो मच मैम।
You're welcome.
Dr. Pooja, I wanted to ask you, do
Yes.
you feel, do you see some gender related issues in head and neck cancer? Is it men who report more or is it women who report more?
Excellent question. You know why? Because if we see that we are blaming tobacco, even our females have come to the level that they also have started consuming tobacco at the same level of males. So I don't think they, of course, we see certain gender differences in certain sites. Like for the post-cricoid, it has been seen. Post-cricoid is the early beginning part of the food pipe in the neck, where we have seen that the female preponderance is higher. So we see more of the post-cricoids being seen in the females. But say, for example, tongue or these based on, there is no such gender bias. But yes, if you're taking such any such culprits like tobacco, alcohol, no matter you are a male or a female or a transgender, you have equal chances of getting the trapped in the vicious circle of cancer.
Thank you.
Welcome.
Dr. Pooja, one more question. Is radiation is carcinogenic or gas or causing secondary cancer?
Very good. Now, this question also has come to our mind more popularly after the COVID era, because during the COVID, there has not been noise that we do a lot of scans and it can cause cancer. So, especially in our field, when I'm claiming that we are, in fact, using a higher dose of X-rays, so probably will not the treatment itself cause cancer? So, it's a very good question. But why it is not so? Because for the cancer to happen, it is usually the low X-rays and it is at the constant level being used. So when I'm trying to give a high dose radiation to a particular defined area, and that is why with these conformal techniques where something called as spillage, we are trying to have the lesser radiation outside the radiation field as less as possible. So chances of secondary cancers are lower. Having said that, of course, we have to make sure that your plan is very perfectly decided to the target and the wanted area only, not to the unwanted areas, because of course the unwanted areas, low dose of radiation in long term can cause some mutations at your cell level, and it can cause cancer. But today with these advanced machines, these are chances are very less. And with that fear, if you refrain your radiation, probably you will cause more harm. So if radiation is indicated, no matter, don't have the fear that radiation will itself cause cancer. So we should not take. Definitely, if your case requires radiation in whatever format, as I explained, pre-operative, post-operative, definitive, or palliative, if the expert says, believe the expert, have trust and faith in him, have faith in the Almighty, and I'm sure you will be having a good results from your disease.
Thank you. One more question. What is the material? What is the material of a mask is being used while giving the radiotherapy?
So I have one mask. I'll show you. So basically, this is a plastic material, right? And what is a mask is, this is a typical head and neck mask where we actually this is a very special property that when you put it in a boiling water, hot water, this will get soft. So once we have a fresh piece like this, it will be soft enough, and then when you apply it on the face, it will take the patient's body contour. Why do we do this? This is the first step of any good 3D planning. When you prepare this, you make sure that your patient is not moving during the therapy, number one, so that when you're talking about precision, you don't want that you have made your plans very precisely, sub-millimeter accuracy, and your patient inside is moving to the extent of centimeters or so. So mask is the number one step, and mind it, this is the first very important step where your entire planning relies. Secondly, what mask will help is that you can put some points on this mask and you can match it with your lasers, because what is important is not just to make beautiful plan, but you make sure that plan is getting reciprocated in the same way. And how do we do that? When we have a technology like this, we prepare mask, we put some points, we make sure match with the lasers, we take a scan again, match it. So mask is a very simple step. It's made of plastic. It is not a big thing. And when, in fact, I would say to my patient, when you will be given that mask in the immersed in the hot water and applied on your face, you will feel as if you're getting a hot water bath. So it is not going to be any painful procedure also. It's very simple procedure, and it is good for your thing that whichever area, we make it for head and neck, we make it for breast, abdomen as per the requirement. And it's a very simple thing. It's a simple plastic, nothing to be afraid of.
Last question. Uh, what are the follow-ups are required during and after radiation therapy?
Good question. So usually what happens is, as I mentioned, the radiation protocol can be anything from 1 week or 2 weeks to months, for about 1.5 months or so. So once the plan is generated, it gets transferred on the machine, the patient gets properly aligned, treated. We make sure any clinical radiation oncologist will make sure that the plan can be seen daily also on our machines and how it is going well. But we make sure that we do physical interactions every weekly, once, at least minimum once in a week, especially in the head and neck, because as I said, no matter you have a very good machine with you, but you have some amount of ulcers happening. So we want to make sure that with all these things, we keep a check on you, and we see that whenever the ulcers start to happening, whatever conservative measurements we have to add, we start on adding, so that we can make sure the patient completes the treatment non-stop. This is also one proven data that if you complete your treatment non-stop without any gaps, the effectivity is going to be better, rather than those patients who are unfortunately going to have treatment gaps for some other reason. So every weekly, we make sure we see the patient, we check the oral cavity, we just write down the supportive medicine as per the requirement of the patient or the side effects. Once the treatment is over, then we call the patient after a month to make sure that whatever side effects he had during the radiation therapy, that are gone. Majority of the times, within 3-4 weeks after the radiation is over, the side effects have gone, the pigmentation has gone, the patient has a good skin. And after that, as per the guidelines, we make it 3 monthly, 6 monthly, and yearly. What guidelines suggested, any patient should be in follow-up up to 5 years. This is a time period where the chances of disease coming back is seen. More importantly, what our experience is, if the patient has crossed the period of 2 to 3 years, then the chances of disease coming back is less. But you should definitely follow the instructions of your treating physician, who calls you as per the requirement, maybe say weekly, monthly, then 3 monthly, 6 monthly, or after a year.
Right. And before I wrap up, one more question. Uh, uh, any patient before undergoing radiotherapy, before and after your care, she can have a fresh use or anything to supplement the treatment.
Very good. So radiation is very friendly treatment. When you come for radiation therapy, you need not to come with some restrictions that you have to be empty stomach or so. So you can have your food and come, or you can go back home and then take your food. Philosophy is very simple. Before entering into the machine and coming out of the machine, you can take anything and everything. Of course, we make some certain dietary restrictions in the sense because we know that this patient is going to have ulcers at some point of the time, or because we expect that the patient has disease somewhere at the post-cricoid region, that is, as I mentioned, the early part of the food pipe. He is going to have problems while swallowing. So we make sure we ask the patient to take as much as liquid as possible, number one. Avoid spices and oily food. Take a lot of ghee. I always tell my patients take a lot of ghee. Why? Because once you take ghee, your preparations become so sticky and smooth that it easily gulps down your neck. Number two, 1 or 2 tablespoons of ghee will also itself give a lot of energy to you. So ghee is a very good thing to take. Like routine chemotherapy agents, where we have a fear that your immunity will go down, radiation does not affect the immunity much. But majority of the times, we all have the chemotherapy clubbed with radiation. So your chemotherapy doctor might restrict you from taking fresh fruits or juices, but that principally does not hold true for radiation. Radiation is a very friendly treatment. Only I always tell my patients is try to maintain the time. Time in the sense, when you're taking your radiation, you see that your radiation is almost delivered at the same time daily, because there are 2, 3 reasons for it. Scientifically, it says if you take the radiation at the same time, no matter, there is no such philosophy that radiation works best in the morning or best in the evening. Whatever time you choose, you're already having a friendly treatment. You don't have any restrictions for the food before or after. Just choose the time which you can reciprocate daily. Because once you take the radiation at the same time, you make sure with 2 radiations you have a 24 hours in difference. The radiation works better. The side effects will be also much in control. And number two, if you maintain the time, it's easier for the department treating you to maintain the time. Okay, this XYZ person is going to come at that time. So we make sure we don't have another person turning up so that you don't have chaos at your treatment hospital. You come and go. We want the patients to be as comfortable as possible, especially in my center. I talk about, I maintain all these timelines so that nobody is wasting time for the other guy. And even if there's some any change in the program, like for example, rainy season of patients coming from long distance, when they value the doctor, they value the treatment machine. I tell them if any reason something goes, you're caught in the traffic, make sure you call at the reception, inform them so that you don't waste your time and someone else is also not wasting your time because of you. So there are simple steps, but these all steps eventually they matter a lot to complete your treatment on time, get the proper treatment, and come out of this disease victoriously as Shrenik Bhai.
Thank you so very much, Dr. Pooja Madam. It was lovely and quite enriching conversation. Say whatever is, I mean, you guys as an oncologist, you are having your own priorities for treating patients, etc. So, I mean, coming to ICS, that a platform, sharing your knowledge with the community, I would say global community. And yes, I mean, this is Facebook live session, and in a day or two, we will be sharing this as a YouTube link so that large number of cancer patients, caregivers can have a clear idea about radiotherapy and so on. So thank you so very much for your valuable time, insightful and enriching knowledge sharing. And we look forward to see you once again. And friends, do join us to our next webinar on Wednesday. Next Wednesday, head and neck cancer surgeon from eminent head and neck cancer surgeon from Tata Memorial is coming to our platform. She has confirmed her participation. So looking forward to all of you. Thank you, madam. Thank you so very much for joining us today.
Thank you. Thank you once again and congratulations, big congratulations to the Indian Cancer Society Delhi once again. It's an excellent initiative. And we as clinicians are always very happy to connect on such platforms, because apart from the clinical work, these type of platforms will really help us to make you more aware, so that you come up in an early stage, God forbid if it all happens. But in early stage, if you come, we also will be able to give you good quality treatment and good results. And congratulations, Shrenik, more and more power to you. Thank you.
And
Thank you.
ICS, let me mention to ICS that Dr. Pooja Madam, she has reciprocated the award she has received from ICS in 2012. So I mean, हिसाब बराबर हो गया, equal
हिसाब बराबर हो गया. Sure.
हिसाब
Thank
कभी
you.
बराबर नहीं होता. We are very forever indebted to her. Thank you very much, Dr. Pooja.
Thank you.
Thank you, Dr. Pooja. It was a lovely session and very
My
insightful,
pleasure.
really, ma'am. Thank you
I'm
so
so
much.
happy that you all have interacted very well. And, I hope this webinar with being streamed later on also will help many more people to understand and not be fearing from the disease or the treatment. Thank you so much once again.
Thank you very much.
Bye.